your audience. So as my co-presenter explained, this is a talk that's around a clinical issue that I have worked really hard with my colleagues that represent community perspective to situate in what community needs are. Many people know that my background is as a nurse. I've always worked in women's sexual and reproductive health and rights and equity, including some work doing reproductive health counseling with people living with HIV. That was sort of my last clinical focus. And now I work as the research lead at the Women HIV and Health Research Program. But as clinicians, we can read guidelines, we can read the science. And I think what's really important is thinking about what community priorities are or community needs are can sort of dictate or not dictate, but sort of add nuance or understanding to how we're counseling. So my hope is that regardless of what audience you represent today here, if you're a researcher, if you're a clinician, if you're a community member, that you'll come away with some understanding that sort of broadens what you knew about reproductive health counseling in the context of HIV. So for some, this might be a bit of a refresher, and for other people, it might be really new. But the hope is that there's some takeaway for everyone. I always like to start any conversation about reproductive health, particularly around women and reproductive health, to focus on the idea of reproductive rights as human rights. And this is something that the team I represent in giving this talk today, which is the Canadian HIV Parenting Planning Guidelines team, really positions as the first and sort of foremost value of the work that we do. So I'm going to read what the WHO, or World Health Organization, says about reproductive rights. It says that this is the basic right for any individual or couple to decide freely and responsibly the number, spacing, and timing of their children, and to have the information and means to do so, and the right to attain the highest standard of reproductive health. It also includes the right to make decisions concerning reproduction free of discrimination, coercion, and violence. And so please know that when I'm talking about reproductive health, I'm equally as much talking about reproductive rights. And I do believe that anybody counseling any person about reproductive health should be doing that from the basis of reproductive rights. And that's how the rest of this talk will unfold. Before we get into anything else around the talk, I think there are 3 things that I have learned over the years in giving this talk to clinical audiences and community members for probably almost a decade now. There are 3 things that are really important that we begin with on top of the reproductive rights piece. So the first piece is that what I want everybody to know is that the reason why the Canadian HIV Parenting Planning Guideline team feels so passionate about talking about planning reproductive health outcomes, planning reproductive health decisions, is because when a parent becomes a parent, when that process happens, when there's planning that goes into it, and often in this situation, we're talking about pregnancy, we're talking about planned pregnancy, it makes the best outcomes for everybody involved. So the pregnant person, the baby, co-parents, whoever's involved in that journey of becoming parent, we have the best odds of healthy outcomes for everybody if we have some planning beforehand. The second thing that's important to remember is that when I talk about planning parenthood, not Planned Parenthood like the organization, when we talk about planning parenthood, this is not a common conversation within every community. So as my co-presenter highlighted in her first question, there's so much diversity across communities of women living with HIV that we need to be mindful as clinicians about this. And this is something I've learned more and more over the years. I will say, though, I think that we can talk about preparing for parenthood with anyone in a way that we can connect to how they go about thinking about it. So I'll give an example. Maybe somebody is from a culture where this idea of planning a pregnancy is not common. I think about in Western society, oftentimes, even for myself or some of my colleagues, the decision to become a parent was very intentional. It was planned, things were laid out, cycles were tracked, exact dates were timed. Even if that doesn't apply to somebody, the way I think that planning parenthood can still apply is that, if somebody could become pregnant, and this is the way I always think about it, if somebody could become pregnant if they're from a culture or have a belief system that doesn't sort of align with this Western idea of planning pregnancy, then I think the best strategy is to always be prepared for pregnancy. And we could talk about that, right? We can talk about, okay, if you don't want to actively prevent pregnancy, then, these are vitamins you need to be taking, or these are other choices you should make in life. And we'll kind of talk about that a little bit more. But it's something I'm always thoughtful about, is that this idea of planning pregnancy does not connect to everybody's belief system. And that even though today I'm going to talk mostly about women, which includes trans women, cis women, gender diverse women, and also in cases of trans men who still have a uterus, it's really important that when we think about reproductive health planning, we're not only talking about women or people who will carry pregnancy, but that we're making this a topic that's relevant to everybody. And this sort of leads into my last point before we get into the information, which is that as clinicians, it's really important to not assume what people's desires and intentions might be, not assume what people's potential to become pregnant might be, not assume what people know about reproductive health and reproductive rights, and not assume what people don't. And so when we take this reproductive rights lens as clinicians, what we're saying is that there's an onus, there's a responsibility on us as clinicians to make sure that we're normalizing and standardizing conversations about supporting individuals in our care to have their reproductive rights met. So what are my objectives for the next 25 minutes? They're to sort of present some really brief background, a little just like context setting about, okay, what do we know about parenthood and pregnancy in women living with HIV and in Canada? And the reason I focus on women is because this is the Women-Centered HIV Care Hub talk, and then to highlight some of sort of the new insights or new ideas that the Canadian HIV Parenting Planning Group is thinking about in terms of counseling, to address some of the key clinical issues that might come up in counseling, particularly what I've learned from community forums, community spaces, and folks like my co-presenter today, and then hopefully to really make sure there's lots of time to have a discussion or answer questions about reproductive health planning. Okay, so the first piece around setting context is that we know that women living with HIV in Canada desire, so want to, and intend to have children. And we've known this even before the study I have cited here, which is was sort of probably one of the most well-known papers published by Mona, my colleague, and the principal investigator of the Women-Centered HIV Care Hub, that looked at the fertility desires and intentions of over 400 women living with HIV in Canada. Now, this paper is 16 years old, but we knew even then, and in data before that from people like Gina Ogilvie and her work in BC with women living with HIV, that there is a desire to have pregnancies, to have children. Now, this data that we have is limited, right? It's specific to cis women. It's over a decade old. It's pre U equals U. And so we could argue that we might assume that those desires and intentions have only gone up, if anything. Now, globally, it's interesting in preparing for this talk, I looked globally, actually, in some countries, fertility rates in women living with HIV have declined. And there's some interesting literature around why that might be the case, including better access to family planning services. But at least in the Canadian context, we know that there's desire and intention. We also know from data from the Canadian Pediatric AIDS Research Group, or CPARC, and their surveillance group called CPHSP, that we continue to see a positive trend in mother-infant pairs. So this slide shows you the number of mother-infants where the mother living with HIV, the mother was living with HIV, and it resulted in a live birth of an infant. And there was a little dip in 2021, but that dip has increased in 2022. And I think the 2023 data continued to show an upward trend again. The 2021 little dip here is suspected to have something to do with this little thing called COVID-19. But we see that overall, over the last 30 plus years, that there's been an upward trend. So again, this supports this idea that reproductive health and having babies is important. Again, the data set is not perfect. It doesn't include things like adoption, but it's some of the best data we have to support the claim that we make as a group, the Canadian HIV Parenting Planning or CHPPG group, that this is a really important topic to keep discussing. So that's the background. Because I think people, what they really want to hear about is, okay, what is the counseling? What are the recommendations? So the second sort of piece to the context then is that we, from the Women-Centered HIV Care Hub, and also from the Canadian HIV Parenting Planning Group, believe that talking about sexual and reproductive health and rights is a critical component of women-centered HIV care. So this may not be standardized in all HIV care settings. Dedicated time to talking about reproductive goals, reproductive plans may not always be seen as part of HIV care. But our position, both in the CHPPG group and also in the Women-Centered HIV Care Hub, sorry, I'm in a hospital today. I'm just going to mute for 1 second. Can you hear that in the background, Mona, or it's not so bad?
We can hear it, but it's okay.
Okay, thank you. And so, even if somebody accessing HIV care has a primary care provider or has a gynecologist or somebody else that might be talking about reproductive planning, might be prioritizing these conversations, what we're saying is that this is still a critical component of women-centered HIV care. It ensures that women living with HIV make empowered and autonomous decisions about their reproductive health, which is part of their right. And that empowerment and autonomy is critical to women-centered HIV care. It ensures that we're addressing concerns around stigma and discrimination, which is another question that my co-presenters flagged, which I'll address a little bit more later. And so the message here to clinicians is that reproductive health is part of women-centered HIV care, and it's something that we need to all be comfortable talking about. And then the last piece to setting the context is that it's 2025. And so at sort of the front and center for a lot of the conversations that we have clinically about reproductive health and plans is sort of exploring and figuring out how U equals U fits into this. So U equals U being undetectable equals untransmittable. And while this might feel like old news in a lot of ways, the last version of the Canadian HIV pregnancy planning guidelines, which I'll come to on my next slide, were finished. So they were published in January of 2018, but they were finished in July of 2017. So it was just on the cusp of what we know now about U equals U. And so there is some growth and there is some change around how we might talk about reproductive options and reproductive planning in the context of U equals U. And that's what I'm going to really highlight today around counseling recommendations. So as I said, this talk is based in the work of the Canadian HIV Pregnancy Planning Guidelines Group. I'm saying pregnancy and parenting interchangeably because anybody who's familiar with this work historically would know of the work as pregnancy planning, but in 2025, we'll be publishing updated guidelines, and those guidelines will switch the language to parenting planning to be more inclusive and respectful of the fact that families are planned and grown in many different ways. The CHPPG work is based in human rights, reproductive rights, evidence, as well as community expertise and knowledge as foundational. And the newest CHPPG version will also have a really strong focus around harm reduction as a foundational component to reproductive health counseling. They're great guidelines. We're proud of them. They were first published in 2012, updated in 2018. Hopefully the 2025 version will be a strong addition to this trio of guideline evolution, but they're long and there are 36 recommendations in them. So today, and in work we've done since the 2018 publication, we've really tried to synthesize and make them a little bit more succinct and, I guess, palatable or usable by clinicians, because it's really hard as a doctor, a nurse, a social worker, pharmacist, a peer worker to figure out how to implement 36 recommendations on one topic into your practice. So these are the three clinical issues we're going to focus on. How do we optimize health before parenthood for women living with HIV? How do we address concerns around HIV transmission risks, including horizontal and vertical transmission? And what are considerations for the management of fertility issues? And as I go through these last 20 minutes of my talk, I'm going to really focus on making sure I identify where I'm addressing my co-presenters' questions, which came from the community. And as I said, we've left lots of time at the end to address any further questions that might evolve from this discussion. Okay, so here's our message from the CHPPG group. Our message is reproductive health counseling, including contraception. Now today, because I don't have a lot of time, I will not talk about contraception or unintended pregnancy at any length, but I do acknowledge that contraceptive use and access to contraception and informed decision-making around contraceptive use is really an important element of family planning or reproductive health, as well as looking at opportunities to improve and decrease rates of unintended pregnancy. But today we're really going to talk about reproductive planning in the context of somebody who would like to pursue becoming a parent. So we're saying that reproductive health counseling, including contraception and any kind of preconception counseling, should happen at the time of HIV diagnosis in any adult diagnosed with HIV and on an ongoing basis annually. So really important at the time of diagnosis, as my co-presenter flagged, there continue to be a lot of misconceptions. And certainly in folks who are new to the HIV community, we've heard a lot around fears that are initially experienced, particularly by women, that they won't be able to grow their families, start a family. So really important as an early diagnosis piece of information that family building is an option. There are lots of ways. And on an annual basis. Now, why do we say on an annual basis? And this comes down to the idea that if we're not systematic about it, if we don't have an approach that's standardized, it's like an easy piece to fall off the wayside. And then we're not meeting those requirements of the women-centered HIV care model I showed earlier. So Mona uses a good strategy where anytime she talks about vaccines, once a year, she looks at her patients' vaccination records, and that's the time of year she talks about reproductive health counseling. People who have an electronic medical record can put an alert in once a year. People might do it January 1st, but my recommendation to anyone counseling is that you find a time once a year in a standard way that you're like, okay, I'm going to make sure that I check in with everybody. What are your reproductive goals? What are your reproductive plans? And how do we recommend that clinicians do this? We developed this algorithm that's available online, and I'll show the links to that at the end, that really walks somebody through in a succinct way how to talk about reproductive counseling. So here you see, our kind of idea is just ask somebody like any thoughts, plans around parenting, family building in the next 5 years. If somebody says, no, this is not the path we're focused on today, the main thing is, do you have any questions? Is there a chance that you might conceive? And if that is a reality in your life, what can we do to prevent that? And we'll chat about this again in a year. Now, of course, if somebody undergoes medical sterilization, somebody is no longer able to conceive because of menopause or any surgical intervention, of course, you don't need to keep talking about it every year unless you think there's an interest to build a family in a non-biological way. So there may be scenarios where you stop talking about reproductive health planning, but they should be limited. Most people who have reproductive health potential, you should be talking about this once a year. Now, if somebody says, yeah, I'm thinking about having a family, the question becomes, is it imminent, like this year, or is it sort of more in the future? Again, if it's more in the future, okay, any questions? Sounds like you don't want this to happen right away. Is there anything that might put you at risk of having a pregnancy? And if you don't want to do that, what are we doing? And then any other individual considerations. For example, if somebody said, yeah, I'd like to become a parent in 5 years, and you said, oh, how would you like to become a parent? And they said, oh, I'm thinking adoption. You might want to say, okay, well, don't wait 5 years to start that process. That can be a long process. Or if somebody is 41 and they have a uterus and ovaries and eggs that they want to use, and they're 41, they say, yeah, I'd like to have a baby in 5 years. There maybe needs to be a conversation about what's going on to help them make an informed decision about their reproductive options. Now, today we're going to talk mostly about somebody who either walks in and says, hey, I want to have a baby, or I want to start a family, or somebody who you screen and they say, oh, yeah, I'm going to get pregnant this year. So this sort of more imminent piece. And that's what we're going to spend a little bit more time going through for the next 15 minutes. So the first piece, and this really answers the very first question that my co-presenter flagged, which is that, there's a lot of diversity. And so the question is, how do we address this in clinical care? So it's pretty easy. It's not that complicated. It's about using, a person-centered approach. And what that means is an approach that's non-judgmental, that's culturally and personally responsive, and that's really centered on their experience. And so these are just some prompts that I think are helpful to think about what are the things you would need to know or understand to provide responsive reproductive health counseling. So the first is, does the person already have ideas or plans about how they want to become a parent? Are they partnered? And if they are partnered, what's the sex or what's the gender of that partner? Do they intend to parent with that partner? If they don't have a partner, is there somebody in their life that they're planning on conceiving a pregnancy or co-parenting with? If biological conception is intended, are there culturally relevant considerations that you might want to think about in advance in terms of again, the value or importance of parenthood, but also just in terms of access to support and things like that. And that kind of leads into the next piece. So many of the things that my co-presenter flagged are considerations or concerns that maybe happen through the pregnancy experience if biological conception is intended or biological parenting is intended, or in the postpartum period. But these are really important to think about in the pre-conception period, in the pre-parenting period. And I want to say, as somebody who's trying to figure out how to raise a 7 and 10-year-olds, these maybe would have been good conversations to have. Like, I want to universalize this. I think we're talking about reproductive health and HIV today, but boy, most of us who are parents would say it would have been better to have these conversations for all of us. So let's normalize talking about who's going to help you, who's going to support you, what are the challenges going to be. And then the last piece is, and are there any beliefs or myths that need to be addressed? Now, I use the word myth very respectfully, and this language came from some feedback and some conversation that Esther and I were having, my colleague within CHPPG. Over the last decade of doing this work, I've learned so many things about what's important around conceiving, or what's important around maybe a biological child, or what's needed in pregnancy, what beliefs there are around what's needed in pregnancy or for a newborn child. And it's really important as clinicians to use a very non-judgmental, very responsive approach to learning about those beliefs or those myths and figuring out how to respect them and integrate them into care in a way that improves the safety of pregnancy for mom and for baby. And so this idea of counseling, to me, needs to be comprehensive, and this is really what the CHPPG walks through. So somebody says, yep, I'm thinking about having a baby this year. And so what are some of those details of counseling? So some of those details of counseling are, learning about somebody's life, their lifestyle, what's going on, what does their nutrition look like, what does their exercise level look like? These are all optimal for, healthy parenting, mental health, well-being, what supports exist, as we already talked about. Are there mental health considerations? We know that mental health struggles can sometimes be more challenging or be worsened through pregnancy and early parenthood, regardless of biology. There's more and more information and data around postpartum or post-parental or new parental depression for men who are parenting. So, what's everybody involved's mental health looking like? And the most important thing here is when we're looking at lifestyle and support and mental health and stigma is that we're using a harm reduction approach, right? Most clinicians will say it's not common to have an experience of somebody, for example, who's struggling with substance use issues, who's actively planning a pregnancy. But if there was such a scenario, it's still really important to think about how can we use harm reduction principles to best support healthy pregnancy or parenting outcomes for that individual or family. And then on a more kind of clinical level, the things to look at would be like some baseline blood work, STI screening, a pap test if it's due for anybody who has a cervix is ideal before conceiving, if pregnancy is the intention. Other health screening that the person might benefit from, if somebody has high blood pressure or hypertension, best to know that before pregnancy, address that if possible. Are vaccines up to date? And the last piece around folic acid supplementation. So all of these recommendations, these clinical recommendations, come from the SOGC, or Society of Obstetricians and Gynecologists in Canada, and they're in more detail in the CHPPGs. One of the questions my co-presenter asked was, what do we do about a pregnancy that wasn't planned? And my answer to that would be, when we'll talk about that in terms of antiretrovirals, but similarly, if a patient or a person comes in an early pregnancy, oh, this pregnancy wasn't planned and now I'm pregnant, this is where I would still start. Like, okay, let's look at some, kind of baseline health things that are going on, what's going on in your life, talk to me about all these things, and then help with that person to make sure that they have access to information about how they want to move forward in terms of that pregnancy, and making sure that they're making an informed decision. We have a more detailed counseling tool that you can access from this QR code. And I would encourage anybody who does this kind of counseling to look at that. The last piece is another question that came up from my co-presenter was sort of like, how do you preserve confidentiality after delivery, including things like giving babe medication and not breastfeeding? I think this preconception period or pre-parenting period is also a really important time to talk about those kinds of considerations. Today's talk is about reproductive planning, so I won't talk at all about pregnancy or postpartum. But in planning for this talk, when we were meeting, we were saying, if we can deal with or address some of those bigger concerns or HIV specific concerns in the preconception period or the pre-parenting period, it really allows the person who's pursuing parenthood to focus on the excitement and the anticipation, and clear up some of the HIV related concerns before entering into that parenting journey. Now, the piece that lots of people have questions about, I'm sure, just gonna take a sip, is around what are the approaches or what are the recommendations around reducing HIV transmission risk? And a lot of this really has to do with ART. So, the first piece is finding out about this person, finding out about what their goals are, what's going on in their life. That's the first piece when we think about reproductive health planning. The second piece we really need to think about when we think about reproductive health planning is what's going on in terms of antiretrovirals, in terms of viral load, if there's an intention to become pregnant. And so I'm not a prescriber, I'm a nurse. So I'm not going to get into details of specific antiretroviral regimens. If there are questions around that, there are more qualified people on this call to talk about that. But here's what I'm going to say in summary around this. So we know that the recommendations around antiretroviral use are that everybody that's living with HIV should have antiretroviral therapy available to them, regardless of viral load and CD4 count. So we can work off the assumption maybe that most people intending to become pregnant are on antiretroviral therapy. If they're not, then antiretroviral therapy should be initiated right away in the preconception period to achieve viral suppression and to deal with any antiretroviral therapy related side effects before a pregnancy is conceived. So the goal is always full viral suppression with management of any side effects before pregnancy. And the priority here is about what is best for the person who intends to be pregnant, what's best for the woman. And so luckily, because of the number of regimens that are available nowadays, the DHHS, which is the Department of Health and Human Safety in the US, their guidelines provide lots of options, recommended options or preferred options, as well as alternative options for antiretroviral use in pregnancy. So the key message here is everybody should be on antiretroviral therapy. For sure, if somebody's intending pregnancy, the ideal is to get them on antiretroviral therapy, suppressed and managed before pregnancy is conceived. Now, in order to address a couple of questions that my co-presenter brought up, the first is how to make sure if the medication that somebody is on is safe for the child or if it needs to be switched. So, I mean, again, we can talk about this in more nuance, but at the end of the day, if somebody's on medication and it's working for them, and they say, I'd like to get pregnant, what should happen is a conversation between the clinician and the person around what we know about that antiretroviral in pregnancy, whether it's recommended or whether it's considered an alternative, talk about why is the person taking that antiretroviral, does it work for them? And really allowing the person to make an informed decision, a shared care decision about whether they would stick with that treatment option or whether they want to switch in the preconception period, if it was a medication that maybe was considered an alternative regimen or a regimen that there wasn't a lot of information about. But at the end of the day, It's really about shared care, informed decision-making. Now, what about if somebody is pregnant unplanned? This is common, as my co-presenter said. Do they need to switch their medication? So again, very similar conversation. And even in the DHHS guidelines, it basically says it is not recommended to change the antiretroviral regimen in pregnancy for anybody unless there's like a really, really strong contraindication. And I think, I can be corrected if I'm wrong later, but I think most modern antiretroviral regimens wouldn't have something in it that's like strongly known to be contraindicated in pregnancy. So it would be more likely that somebody would be on a medication that we maybe don't have a lot of information about, but the recommendation is not to change it just because of pregnancy, if it's working for the pregnant person. Because again, the priority is always what's the optimal treatment for the individual. Okay, so what about viral suppression? So here we go. If somebody meets that criteria, they're on antiretroviral therapy, they have a fully suppressed viral load, and they've had a fully suppressed viral load for 3 to 6 months at least. That's what the Canadian guidance says. HIV is kind of clinically irrelevant. So when I say clinically irrelevant, what I'm trying to stress here is that as a clinician, I'm going to talk about it, but my clinical recommendations are far less important around HIV, but I recognize and respect as a clinician that as a personal, they may still be very, very relevant. And the only kind of caveat I have to that is that if a woman living with HIV has a complex gynecological history, so maybe they had a sexually transmitted infection, or they had a period of an undiagnosed, untreated sexually transmitted infection, it may be important to think about slightly earlier screening around fertility, because we know that long-term inflammation and infection in the pelvis for a person trying to conceive can be problematic. So that would be the only kind of caveat or consideration for me. Now, if U equals U doesn't apply, and we can talk about scenarios where that might happen in the context of conception, HIV remains a clinical consideration. Again, our recommendation in 2018 and our recommendation in 2025 is the Canadian HIV Pregnancy Planning or Parenting Planning Group will be, ideally, the individual would get on antiretroviral, they'd suppress for 3 months, they'd meet the requirement for U equals U, and then they would pursue conception. That's for horizontal transmission. And then we know from data from a group that conducts something called the French perinatal cohort, that in people who have an undetectable viral load before pregnancy, throughout pregnancy, and at the time of delivery, there have been no cases of vertical transmission in over, I think, 5,000 observed cases within that cohort. So for the benefit of horizontal and vertical transmission, the ideal is viral suppression. But if a person or a couple intend to conceive immediately, the focus is on risk reduction. And I get asked sometimes, like, what would be a scenario where there wouldn't be an opportunity to wait for U equals U? And there are a couple that come to my mind. A scenario where a person's partner is only in the country for a short period of time, maybe they're newly diagnosed. And also our fertility colleagues have pointed out, somebody who might be on an IVF wait list, which is like funded in a province, and most of those have an upper age limit. And if the person's about to meet that upper age limit, they may not want to miss the funding window for IVF. So it's really important to remember that even if most of the time we expect U equals U to count or to apply, we need to be prepared. We need to still be clinically sharp around how to counsel when U equals U doesn't apply. So here's the fertility formula. The fertility formula is a woman, because we're talking about the Women-Centered HIV Care Hub, a woman who has a desire and intention to become pregnant, somebody that we understand what their viral status is. Then we take all of that into consideration about them, about what their desires are, what their viral status is, and we tailor our counseling specifically for that individual. And so for most people, this will involve going through the different options for conception. And, this used to be something we spent a lot of time talking about, but I think I've learned over the years that the most important thing is the stuff we've already talked about. It's the How do we counsel in a responsive way? How do we make sure we're prioritizing our understanding of U equals U? And so, you know, a lot of these options are not rocket science. Most of us know what condomless sex is. If you don't know what condomless sex timed with ovulation is, it's basically helping somebody understand their fertility cycle and knowing what window in the month they're most likely to conceive and making sure that they're maximizing conception attempts in that window. Now, before U equals U in the context of HIV, we used to recommend condomless sex timed with ovulation because it reduced the number of condomless sex acts. And so it's really important in modern counseling that we clarify that this is not about horizontal risk reduction. It's really just about the fact that you could have a whole lot of sex on the wrong days and there's zero chance of getting pregnant. So for somebody who has a partner and they have, you know, there's sperm and there's eggs and there's potential to make a baby, you know, this would really be the recommendation is timing condomless sex with ovulation if that fits for the people, if that feels comfortable. And here's a little QR code that takes you to a link that talks about learning how to track your ovulation if you don't already know how to do so, or if somebody wanted to provide that to a client or a patient. In some scenarios, PrEP may be recommended. And again, the DHHS guidelines have considerations around PrEP use for conception, and so too will the forthcoming update to the CHPPG guidelines. Again, really important to remember that even in the context of U equals U, PrEP may be something that is prioritized by people. And then lastly, options for at home would be, home insemination, which is probably just like what it sounds, which is getting sperm and doing the insemination process at home. And again, while this used to be more common where there was a woman living with HIV with a male partner or a male co-parent before U equals U, it's still an option for people who might be planning to co-parent with somebody and they don't want to have sex with them, or for individual reasons or considerations. Again, this is just a little bit more about PrEP, but I'm speeding up because I've noticed what time it is and I want to make sure that there's time for discussion. And these slides will become available, but just a reminder that we're talking mostly about women living with HIV today, but also that PrEP is an important consideration when counseling conception to a woman who may benefit, an HIV negative woman who may benefit from PrEP during conception or conceiving attempts, and that it's recommended and available. Now, fertility care or fertility treatment, again, we talk about mostly just because anybody who wants to try to conceive biologically may run into issues or challenges in conceiving. So it's important to understand fertility access and fertility access concerns in the context of HIV. Some kind of high level things to know is that we do have some data. It's not so much in the U equals U era, but we do have some data that suggests that there might be slightly higher rates of infertility amongst women living with HIV compared to the general public. And some explanations of this are, again, what we're learning about HIV and inflammation. And this is a real focus around things like HIV and cardiovascular health, HIV and aging. So understanding the connection between HIV and inflammation. It's kind of universally of interest clinically. History of co-infections, or particularly, again, I was talking earlier around sort of pelvic inflammatory infections or pelvic inflammatory disease, and then obviously some unknown mechanism that's not understood. And so in general, the Canadian HIV parenting planning guidelines do say that based on individual considerations, you may want to recommend fertility screening earlier in a woman living with HIV, but the general recommendations in there are primarily based on standard recommendations and age-based recommendations, but not to hesitate an early referral if there's any indication. And regardless of whether it's a fertility issue or whether it's it's a risk reduction strategy in the context of somebody with detectable viremia or an individual consideration, it's important to understand options that are available at fertility clinics. So these include intrauterine insemination, which is when essentially like a pellet of sperm without the seminal fluid is placed inside the uterus. In vitro fertilization, which is fertilization that happens outside of the body. And then fertility clinics are also accessed for individuals, whether they're single or partnered, who need access to donor egg and donor sperm. Now, the truth is that there are ongoing challenges around access to fertility clinics. and comprehensive fertility care for people living with HIV throughout Canada. So any care provider who is counseling an individual around access to fertility clinics, we would encourage you to for sure reach out to us if you want to. We have some inside sense of what fertility clinics offer services and what scale of services they offer to individuals living with HIV. And this has been a big focus of the work within the CHPPG team in the last year, is understanding policy, legislation, regulatory documents, and now we understand they're called directives and guidelines. There's layers and layers of policy to help dispel any ongoing myths, confusion, or discrimination that happens on the basis of assumed legislation that makes it challenging for clinics to provide comprehensive fertility care. Working with some great fertility lawyers who are helping us understand that, the truth is that all fertility clinics in Canada, by government legislation and regulation, should be able to and willing to provide comprehensive care to people living with HIV. And this is something that we're working towards. So some of those ethical and legal considerations that we got asked, particularly around fertility care, I just want to flag. So the first is that disclosure considerations may look different in fertility legislation than they look in HIV non-disclosure law. So if somebody has an undetectable viral load and they're looking to conceive spontaneously, from an HIV disclosure legislation perspective, they don't necessarily have to disclose their status. But if somebody is a directed donor, which means it's like somebody who's known to another person and they're donating sperm or eggs, or even if they're in the context of a relationship, the medical director may require disclosure of HIV status. Similarly, if there's surrogacy involved, the same guidance for directed donation would apply. So it's important to understand that you're dealing with different legislation or different regulations in fertility clinics than just HIV disclosure law. And I'm not a lawyer, but this has been a really important piece to start to understand. Apologies. The last piece is around adoption. And I feel like we never give adoption enough time. One, because there's too much to talk about, but the other is that we just don't know a whole lot about it. But here's what we know. For a person living with HIV who's interested in pursuing a domestic adoption, meaning adopting a child in the Canadian system, whether it's public or private, HIV is not prohibitive. For international adoption, so somebody who might be looking to adopt from another country, including whether that's your own country of origin or not, there are challenges. Now, we haven't looked at the actual facts of this in a long time, but the last time we looked at it, there were many international countries that still listed HIV amongst other medical conditions that would preclude or prevent somebody from being able to access international adoption. And my understanding of this is the same in kinship adoptions as well, which is when you're looking to adopt somebody from your own family from a different country. Again, what are some ethical or legal considerations in the context of adoption? So the first is whether it's a domestic or international kinship adoption. This would include a medical assessment as well as a home study in which your HIV status might be disclosed to more people than you would typically disclose to. So it's something to be aware of. And that, adoption workers or prospective families may not be educated about HIV. And so there does run the risk of possible discrimination in that process. And that these are some of the things that my co-presenter was flagging and that we really want to ensure people are prepared for. Now, as clinicians, we've made this really great resource. It talks about reproductive rights and being sort of a champion for reproductive rights of people living with HIV that can get put up in clinics. There's also an example for community members that can get put up and shared in places. And at the end of the day, the question that got asked to me about, what about discrimination and what about laws? The basis of everything is reproductive rights. We can get more specific, we can get more nuanced to that, but at the end of the day, from preconception until all the way through parenting, there is a right to those reproductive choices and options. And so it's really hard and really challenging when those rights aren't met or recognized. And hopefully at a minimum, there's a sense that where an individual accesses HIV care is a safe place to come and ask questions. But all we can do is continue to share this information and share it broadly so that people feel those rights can be met. These are a couple of sources that we've created. The first link is primarily for clinicians, and the second link has been developed by community members to focus on HIV, reproductive health, and parenting choices. And so I do encourage you to look at those. In terms of other, in terms of other resources that are available, which got asked to me, in Toronto and in Ontario, we have the Teresa group. I think through many parts of the country, community-based organizations have women's workers, community support workers, family support workers who may be able to offer unique support to families and women living with HIV who might be considering parenthood. Most provinces do have a formula feeding program if formula feeding is the preferred way of feeding your baby or future baby. And so, it's not an ideal system. There isn't a perfect set of resources, but there are some sources of support to answer that question. And I'll just leave everybody with this idea. Mona and I are involved with an international group and have gotten to know a really great colleague who developed this group in the UK called 4M. And 4M is a mentor mothers group across the UK of women living with HIV who provide mentorship and support to their peers who are becoming mothers. Their motto here, my health, my choice, my child, my life. And it's maybe a bit of a call to action that in addressing that question of where to get support, it'd be pretty great to see something like that developed and ways to sustain that kind of work in Canada. So I can stop being recorded. I've gone